Our next speaker is Dr. Sherif Boulos of Resonance Health, and he's going to talk about Ferritin and Haemochromatosis. As previously stated, Resonance Health are our sponsors, and Dr. Boulos is their clinical research manager. They're the company behind Ferritin. He's originally trained as a molecular biologist and researched a number of diseases with genetic associations, including Parkinson's disease, cystic fibrosis, spinal muscular atrophy, as well as brain cancers. Dr. Boulos is responsible for establishing and overseeing clinical trials set up to test the benefits of non-invasive imaging. It brings an understanding of disease process at the cellular level. I'm intrigued, Dr. Boulos, as I'm sure everybody else is, so thank you.
Thanks, Hannah. And thanks, David. Thanks for inviting Resonance Health, and it's been a pleasure. I really enjoyed the talks this afternoon, so hopefully I can contribute something to the field today. So, to put you in the background, Ferritin was developed by Tim St. Pierre. He's a professor of physics at the University of Western Australia, and the technology is licensed to Resonance Health. I think the technology now is, it's been around for maybe 12, 13 years. And part of what I'll do today is just talk about the development of the technology, why it has applications for diagnosis in hemochromatosis, and some of the strengths of the technology, and some of the different applications, how it can be used in hemochromatosis. So I won't labour the point about the condition. All of you pretty much know how it arises, that it's an endocrine disorder, and at the basis of at least hepcidin-related hemochromatosis, it's a change or a drop in the level of the hepcidin serum levels. We heard that there are a number of different types of variations, gene defects that have been identified, that all converge on the control of hepcidin and obviously the iron absorption. As you know, it's common in people with Northern European origin, and as you know, there are one of the main HFE-related types of mutations is in the C282Y. Okay, I'll probably leave it there now. This is just an illustration, and I think it's on one of our brochures that, if you like, is an algorithm that helps you, I guess, trace what you would do if you had a high serum ferritin. You may have your HFE mutations identified, if that's what the clinician sought to do. And then you can actually have an iron test to see how much iron is loaded up in your liver. And there are a number of different ways you can do that. And from that, you can then arise at some sort of therapy. So why do you really need to know what your liver iron concentration is? Well, it helps for a start because the liver is one of the major stores of iron in the body. Okay, so if you know how much iron is in your liver, then as a way of treatment, you know through phlebotomy you can reduce the levels of that iron, and that will bring you into much more of a normal range. Now, if you have an accurate measure, which we think the Ferriscan system is, you can then tailor your phlebotomy to suit the amount of iron that you have in your liver as detected. And then you can make sure that you have enough phlebotomy and that you don't have excessive phlebotomy. And the reason you do this, because we all know that persistently high levels of iron in the liver can lead to liver fibrosis and cirrhosis, and sometimes that can lead to liver failure. Okay. Another risk factor is the development of cancers, hepatocellular carcinoma. So if you have high fibrosis levels in your liver, or if you have a cirrhotic liver, you can develop HCC, which is a very serious cancer. So with people that do have high iron in their liver, they ought to be monitored for HCC, and that's a recommendation. The other thing that we were able to discover as well, by measuring iron, we found that in newly diagnosed patients, for example, we were able to
predict the degree of fibrosis in their liver just by knowing their age and their iron levels at diagnosis. And I'm going to talk about some of those studies later. So how would you determine your LRC and how would you do it effectively? Now, most of what we know, most of you, I guess, would be aware that you can have a liver biopsy, and that's a very invasive process. You can use a technique called SQUID. There are currently only 2 sites in the world that are able or equipped to use SQUID to analyse your LICs. Or you can use computed tomography, which is a technique that requires X-rays. So with magnetic resonance imaging, that avoids a lot of these pitfalls, and that's kind of what I'm going to sort of talk about today. So liver biopsies, there's several different ways you can obtain a liver biopsy. You can do it percutaneously, laparoscopically, or transjugular. But all of these different modes have an association of certain level of risk and complication. So we know that a liver biopsy could lead to 1 in 10,000 deaths, okay? Bleeding in 1 in 100 people, bile leakage 1 in 1,000 people, significant pain and pain during the procedure. So it's not an ideal technique from a purely invasive perspective. But then what about the accuracy of biopsy? And then that's probably an equally important point as well. So this table just charts out the different studies that have looked at the degree of accuracy, if you like. So the higher the number it is in percentage, the worse the degree of accuracy. So currently, most liver biopsies are needle biopsies, and you can see the coefficient of variance is 19%. So still a degree of error associated with it. One other thing to bear in mind with a liver biopsy is when you take the sample, it's only from a single region of the liver and only a very small sample. So there's what we call a sample size error. Okay? It's not highly representative of the whole liver. Okay? A lot of these studies are not just for, conducted for haemochromatosis, but for other different types of liver diseases, like beta thalassemia, for example. So there are inherent sampling errors associated with liver biopsy, and that's something to keep in mind. So with MRI, which is the technique that we developed through the University of Western Australia, and we call that technique FerriScan, and this is, you'll see the brochures in your packs that you all have. So what it relies on is MRI, so magnetic resonance imaging, and that's an MRI machine on the top left of that slide. And how it works is you apply a magnetic field to the patient, very localized magnetic field, and then you induce these changes in the tissue. And then when you induce this change in the tissue, then you are able to detect this change in the tissue. And we know that, for example, iron is able to affect the signal that we receive. Okay, and that signal gets recorded. So in those 3 boxes, you can see this transverse section of a liver, and the liver's highlighted, it's been traced around, and you can see there's a change in the liver in a very specific way. We call it a decay rate, and it's what we're measuring. We're actually looking at what we call an R2 value when we measure this liver change. And I don't want to get into the technical side of it, but effectively we're able to measure a change in the liver that is correlated with the amount of iron. So we know we can do that. Okay, so if you have a look at this image, we call this this Proton transverse relaxation rate. Okay, and you can see this image of the liver, and you can see it all coloured brightly in yellow. That's just for visual representation. It's not what happens to your liver when you're in an MRI, but by knowing that relaxation rate, we can tell you exactly what your liver iron concentration is. So in this example, it's 7.7 milligrams per gram of dry liver weight. And that graph on the right-hand side basically just gives you an idea of the total amount of liver iron. So it's probably not enough just to be able to measure it. We need to be sure that we're measuring the right thing. Okay? So this slide just basically shows you what the liver looks like in terms using this R2 measure, okay, in an MRI. And you can see that our top panel is a non-iron loaded subject, so there's not a lot of yellow, as you can see. And then we've got 3 iron loaded patients, and you can see as the iron loading goes up, so does the intensity of this R2 signal, which is what we can measure very accurately. So it's a direct correlation between the iron in the liver and this R2 value. Now to ensure that we're actually measuring iron, what we've done, and this is a leading paper that was published 2005, we took over 100 patients and we biopsied those patients. So we took a biopsy from them and then we physically measured the amount of iron in that biopsy. So it was a chemical analysis, so we knew how much iron was in those biopsies. And then we measured their R2 values, okay? And then we generated this curve. And that curve basically is our calibration curve that allows us, with confidence, when we measure R2 or when somebody goes into an MRI machine and they measure R2 values, we can be very confident what their liver iron concentration is. Okay? So it's a very sensitive and very specific technique. We've shown that it's accurate over the full range of the LICs that you would typically find. So I think it's, you can get measurements up to 35 milligrams per gram of dry weight, and as low as, almost 0.3 milligrams per gram of dry weight. So it's a very accurate test. We know that it's unaffected by inflammation. It doesn't matter if you've got fibrosis or cirrhosis. It's effective independent of those parameters. It's unaffected by age. So adults, children, it's the same technique. We've also validated, and this is what we call a validation study. We've validated this in a number of different scanners. So it doesn't matter if your radiology centre has a Siemens or if it's got a GE or a Philips, you can still use this test, okay? The other thing we did to make sure that the testing of the FerriScan technique is accurate is we scanned people twice. So we put them in, we scanned them, took them out of the MRI machine, put them back in again and scanned them. And then we measured the R2 values and compared them. And you can see that line, that very straight, almost a 45-degree angle, that tells us that it's repeatedly accurate. So you go in, have you measure, and then a subsequent test confirmed that it was the same number. Okay? And then we did what we call the Bland-Altman analysis. I won't go into that, but basically it tells you the degree of variation between the two measures, and it was very insignificant. When we actually did the statistics, we found that our equivalent standard of error, okay, remember when we talked about the biopsies, if it's standard biopsies about 19%, when you do it with the FerriScan, it's only 15%. So that tells you that FerriScan is better than doing a biopsy, okay? You don't get the pain, you don't get the inconvenience, etc., and the risk, and you get a better answer, okay? That's an important point. When you look at the sensitivity and specificity of the test, in this instance you want to see very high numbers for your sensitivity and specificity. Basically it's a statistical tool that tells you how accurate the technique is. Okay? So when we're looking at the upper 95% of normal, which is recognised as a 1.8 grams of iron per gram dry weight, you can see the sensitivity is 94% and specificity is 100%. And going down the list, these are different thresholds which we highlight on our brochures, which are regarded as critical thresholds for clinicians. And they use these thresholds to then specify a treatment. Okay. You can see at 3.2, we talked about thalassaemic patients, they often will receive transfusions, okay, and that's the limit that they would work to as their lower limit, and then going up from there. Okay. So that table basically tells you how the FerriScan result fits in with the different clinical thresholds and how accurate it is against those clinical thresholds. So 94 and 100% for 3.2. You probably know, some of you may know what your liver iron concentrations is. That would tell you how accurate or how confident you can be with those values. Okay. So this is a typical report that we send to the clinicians that request a FerriScan. So on the left-hand side, you can see that familiar transverse image of the R2 values that you would see in the size of the histogram, which is basically just the amount of sort of area under that little hill-shaped material. We provide a concentration value, 6.8 in this instance, 6.8 milligram per gram of dry tissue. And on the right-hand side, you can see basically a historical chart of the liver iron concentration for that patient over a period of time. Now this patient, I think, was a transfused patient, you know, so it's very critical to know exactly what their iron loading was. And you can see with continuous monitoring, their iron loading came down over time. Okay. Now, the other bits of the report show you that it's TGA approved, so you could be sold as a medical device, which is what we sell it in the United States and throughout Europe and Australia. So in terms of the key facts about FerriScan, I've shown, I think, that it's superior to biopsy. I hope it wasn't overly technical. So we know it's probably the most accurate measure of liver iron concentration, suitable for any scanner, and tell you that it is safe. We don't use a contrast agent. Okay, it's relatively quick and painless. Well, there's no pain. I mean, if you're the sort of person that isn't happy about confined spaces, that's an issue. We endeavour to get the results to the clinician within 2 days, so there's no waiting around. Okay, and as I said, it's FDA and approved in the US, in Europe. The other thing that's unique to us, we do all our analysis in Western Australia. So using a web-based system, the image that the radiologist acquires after you go in the scan just gets uploaded to our site in Western Australia. So virtually we're working while you're asleep, okay? Which is what allows us to get those results back quickly. All right? All that analysis that we do, for us to get TGA approved, okay, the TGA come and they inspect our facility, and the same with the FDA. They have to come and inspect our facility to make sure we are complying with these very high standards that they set, so that the numbers we provide you for your liver iron concentration has to be within a very narrow range. Okay, that it all has to be supported scientifically. That's how we do it. Okay, this is somebody going into a scanner, and you can see they have a it's a coil that they put above the abdomen, and then they roll them in, and the scan's completed within 10 minutes, so it's relatively quick. And you can see in the panel below, a patient being shown her FerriScan report. As I said, it's a quality product, so you can have the confidence in it. Every year we ensure each MRI machine is fully validated, so we use what we call a phantom pack. I wouldn't get too excited about that. All it basically means is we check to make sure the MRI machine is working properly and is within the right calibration to get the best result. There's no specific hardware or software that's needed to be able to run the FerriScan. We remotely deal with the radiology centres, and so we tell them what numbers to dial into their instruments. And as I said, any number of different types of MRI machines, you can do this. Now, at the moment we're in over 200 centres across 30 different countries. So not just looking at haemochromatosis, but thalassemia, sickle cell disease, and a bunch of other type of diseases. To date, we've performed more than 30,000 Ferri scans successfully. Now, Melanie up the back, she's our local representative. She can help guide you through if you're interested in having a Ferri scan done and your hospital hasn't been set up. She's the person to help you do that and achieve that. Okay, I'll just move on. So I thought what I'd do is include a couple of different studies that may help sort of broaden the applications of Ferri scan and how it can potentially help in getting a bit more detailed information. So the question I've posed here is, can your LRC multiplied by age at diagnosis predict liver damage? I've posed that question deliberately and the answer is yes, but I'm going to show you the study that basically backs that up. Now, in Western Australia, there's a clinician gastroenterologist that we have worked with a lot. His name's John Olnick, and he published this study with us. And what he basically determined in this study, he said, okay, he measured everybody's LIC. He didn't use Ferri scan completely with this, okay? Part of the study included Ferri scan, but in this case he used biopsy. And he determined that if you take the LIC, multiplied it by a person's age, this is at diagnosis, you can get a pretty good idea about the degree of liver fibrosis that patient may have, okay? And that, because everybody's different, they're different, they load iron at different rates, etc., and that people will be diagnosed at different ages, you can then separate people into these kind of different groups. So generally they'll fall into this lower high grade level of fibrosis. Part of this study involved doing MR. On the right-hand side, you can see this panel. I must point out that probably we didn't have enough subjects that went through the MRI machine before this data was published, but we are building on that. But effectively, it's a kind of very simple way of working out how affected your liver might be. Again, depending on what your existing LIC is and at what age you were diagnosed. Okay. So the principle behind that is the longer you have a higher iron load in your liver, the more likely you're going to develop fibrosis. We've heard a lot about serum ferritin, and Ted explained his very interesting study about using serum ferritin to identify potential candidates who may have haemochromatosis, or at least the haemochromatosis gene. But he also discovered that there's 80% of his cohort that he looked at didn't have haemochromatosis. So that's interesting itself, and it sort of follows on from what we've found as well. So we did a study, we looked at these patients, and we asked the question, can you use serum ferritin to predict how much iron a person is likely to have? Okay, so we use what we call quantitative phlebotomy, so we remove blood, and Ted described exactly how much iron can be removed for every pint of blood. I think you use pint in the UK. And we found that if you looked at the serum ferritin levels and you looked at the amount of iron you removed, they didn't really correlate all that well. There was a little, they reflected slightly, but it wasn't a strong indicator of how much iron your body was storing. This is a study moving forward in time. This is a study by John Olnick, again, and he looked at, I'll just point out the two groups that are probably the most interesting, and these groups are either those with haemochromatosis or non-haemochromatosis patients. And if you were to go by even the transferrin percentages and the serum ferritin levels, you wouldn't distinguish between those two groups yet. One group had haemochromatosis and the other group didn't. Okay. So that was a study published in 2009. So that's why we're saying it's probably not an ideal measure. But if you look at the LIC, if you're doing the same experiment again, in other words, if you took blood away from your total body stores of iron, and you do that quantitatively, it means you know how much iron you're removing from the body, that iron would be reflected in your liver iron stores. So that's really important. So your iron is actually, your liver iron concentration is actually telling you what your iron body stores of are. Okay? So we found that is a very reliable correlation. In terms of serum ferritin, part of the reason is that serum ferritin is an acute reactant product, that it just appears in the blood, and it's probably an indicator of many other different potential diseases or conditions that may be the underlying cause. One of those is non-alcoholic fatty liver disease, and you'll probably hear more about that disease as time goes on. And I've picked out from that list, and you can see that there's many different organ systems that are affected that can affect the serum ferritin levels. So we think that really, and EASL, which is the European Association for the Study of Liver Disease, they recommend that serum iron concentration and transferrin saturation do not quantitatively reflect body iron stores and should therefore not be used as a surrogate marker of tissue iron overload. Okay, and that's on their current policy headlines. This is just a case study that was published. It's about a Caucasian patient, 39 years of age, and probably a lot of you would maybe identify, or half of you at least, maybe identify with the presentation of the different types of symptoms. This person had aches in his joints, his hands. He was lethargic. They did a full blood picture. They looked at serum ferritin levels. They were high. They tested for mutations for Haemochromatosis. They didn't find any. But then when they looked at his liver iron concentration in his ferry scan, it was clearly evident he had a high liver iron level, and obviously from then received phlebotomy, and that phlebotomy that was quantitated against the amount of liver iron in his body. Okay, so that's just one example of how that can be used to help in terms of treatment for somebody with a queried iron overload without a confirmed genetic identification. So I just want to summarise with FerriScan and what it means in haemochromatosis. We believe that it accurately determines your LIC, at least it's superior to biopsy, and we know now quite a number of different societies. So the Thalassemia Society has now given its tick of approval to FerriScan as the most accurate measure. We know through our own studies with other clinicians that it can accurately calculate and determine your total body iron stores, which we think could be useful when you're planning your venesection. In a sense, you don't want to over-venesect, you don't want to under-venesect, and this is a way of being able to achieve that. It'll help monitor the change over time, and we've done some studies that show if you, in newly diagnosed patients, for example, you're able to determine with some degree of confidence the likely degree of liver fibrosis. Okay. So that's another useful thing. I hope I've shown you serum ferritin is not a reliable indicator of iron loading in the liver. And we believe that it's a very good technique to assess your risk of iron loading and hence your potential degree of liver damage. Okay, I think I've laboured that point. The other thing I wanted to go back to, because it's an issue that we're also investigating at the moment, and we have a technology that's able to do so, and that is to look at StatOSIS in the liver. And I think it was in David's talk he discovered that StatOSIS was a potential risk factor. We certainly know that StatOSIS being liver fat, the deposition of liver fat through arising out of increased body mass, more than likely, and metabolic syndrome, that can lead to potential damage to the liver through a process called non-alcoholic steatohepatitis. So that's an inflammatory process that causes further damage to the liver, and that in itself can lead to fibrosis. So it's an issue that probably needs to be addressed more and more as time goes on because of the increasing rates of obesity. This is, again, an MRI technique, and I won't go into too much of this. Let's just so that you're aware of this potential technology. Okay, this is a biopsy showing the fat droplets that accumulate in these liver sections, and this is how we do our validation for that, in the same way we've done our validation for the liver iron concentrations. And again, we're using biopsy to confirm our results. Okay, and I won't labour the point anymore. Okay, thank you for your